it says posterior, blah, blah, blah. So that's just the view, okay? And the little dot in the view is kind of telling you the segment. It's giving you an idea where that segment is, okay? Now, if you think about second handout, the lungs and bronchial trees, nice pretty color handout. Take one. So if you're looking at the lungs, like this, here's my lungs, and you want to drain this segment up here, see how there's like a secondary.
Did you get one?
Need one?
Yeah.
Oh,
Thank you.
there you go. Oh,
This one's color.
yeah. I spent a little money on this one. I think that's two there if you grab one. Okay, so if this is my lungs and I want to drain here, do you see how I have to get this down and then over into the main bronchiole? So sometimes when you're looking at lung segments, refer back to this. Because sometimes people say, oh, it doesn't make sense that the right side's elevated for this, but it does here, because you have to elevate and get to the right side to drain it to the central. And that's our goal, is to get the fluid in the lungs to the central bronchiole so that we can help the patient cough and get it out. Follow me so far? Okay, so it is a little confusing. Take your time, look at it when you're working through it. And we will, work through them, and I'll help you if you have any trouble understanding. So, in your book, page 554 are all the precautions and contraindications for 1, postural drainage, and 2, percussion and vibration. But think about it a little bit. I'll recap all of them, but in general, for pulmonary drainage, what are some precautions? Low blood pressure, so if they're elevated, maybe. But what else? Sometimes you have to Trendelenburg people. So CHF, do we want to get all that fluid back in, exacerbate that? What else?
You're talking about just postural drainage?
Just postural drainage. Think about position. If I'm going to Trendelenburg somebody, head down, what does that do? Sends everything up this way. So what does it do to the pressure? Increases. What kind of people do you not want to increase intracranial pressure with?
Stroke.
Head trauma, stroke patient, right? What else is up in this area? Eyes. So recent eye surgery. Think about the things that you may see in a patient's history that you don't want an increased pressure to that area. Spinal cord, if they've got autonomic dysreflexia, we're not going to have them head down. We could maybe create that problem, right? Okay. Of course, if we're looking at cardio, you think about hemodynamic stability. If somebody's not stable from that standpoint, you're not going to be doing that kind of stuff. Anything else for postural drainage that you can think of? I'll rattle off the list in a second, but maybe not necessarily though, because you're not going to have them in that position for very long. So if you have some arterial problems in the lower body, you are theoretically draining the lower body of the blood, but it's not really going to be that long that you're going to get ischemia or something like that. So pleural effusion, a large pleural effusion, you might not want to do that. And we kind of hit everything else. Ascites is one of them. We talked about pressure, we talked about hemodynamic stability, we talked about spinal cord, head trauma, eye surgery. This one says diaphragmatic hernia. So you can think about it, you don't want to have them that way if you've got a hernia in the diaphragm. And then if somebody's coughing up blood, we don't want to encourage that to happen. Now think about what we just talked about, trying to adjust the positioning and put vibration and percussion up to it. What precautions are increased there? Any fractures, correct, especially in the trunk or the rib area. What's that?
I said systemic cancer.
Cancer, right, especially in that area, metastatic to the bones. Who else is at risk of fracture? Osteoporosis, osteopenia. Okay, and then, you know, position-wise, the same kind of precautions that we said before. Not so clear because we don't always have a patient to kind of compare it to, but if there were burns or wounds in that area, would you do it? No. So, you know, some of them are very obvious if you were given the patient that you wouldn't do.
Bruise easily.
Yeah. Tumor. You said cancer, but if there's tumor in the lung or tumor in any of the ribs, metastatic kind of covers it all. And then the other couple of things are if they have seizure activity. We didn't mention that about the first one, but again, somebody has seizure in their history, past medical history, you probably don't want to have them head down to increase that pressure there. And then if I'm percussing up in this area, what do I have to be careful of? Think about cardiac. Which usually over here.
Pacemaker.
All right, lines if they're acute, but what's a procedure that pacemaker? So anytime there's a pacemaker, you don't want to percuss on that side. Sometimes they trick you and put the pacemaker over here, but you'll know when you see the patient. Sometimes the right, you know, they have a problem with the left side, so they'll kind of put it central on the right side. But again, some of the precautions, I think, if you're thinking about it, are going to be pretty clear. You know, if he has a wound there, I'm not going to be hitting on it. If he has a broken shoulder or rib, I'm not going to be hitting on it. If there is a history of osteoporosis, I might try to be cautious, but I might just do the postural drainage part of it and not add the percussion or vibration. So I can still get some effect maybe, but not, you know, all that trauma, so to speak. Okay. So what I'd like to do is we have 2 beds. They're going to fully go Trendelenburg up and down. The controls are going to be at the foot of the bed. On that one, they're pretty right on the back, and on this one, there is a little cover that covers them. And then on your high-low tables, we have wedges. And then this is a tilt table, so you could, depending on where you lay your head, be in Trendelenburg or reverse Trendelenburg. The problem with this is, especially for me, maybe some of you taller guys would be okay on it, is that when you percuss or when you vibrate, you want to have a good biomechanical advantage. So if I had somebody on this table, it might be hard for me to do it. And you'll find that if you do it for a little bit, you're going to feel tired, especially in your forearms and your arms. So you want to get in the best biomechanical position to do that. If I think about positioning myself to do percussions, what kind of things come to mind? Well, you want to make sure that you do or can observe or
their face for a reaction.
want to make sure that you can see their face. Sometimes it might be difficult. If you're back here, percussing up here, you might have to, you know, kind of take a side view every now and then. Or if you can percuss up here. But again, sometimes with me right in front of you, kind of do some percussions that can be a little, anxiety might be another precaution. Just because of, you know, if you're in front of them and you always ask permission, always let them know where your hands are going to be. For you males and females, vice versa, make sure that, especially for the upper lobe, you get permission. Talk about where your hands are going to be. Sometimes you have a little female and large hands. They might use one hand as opposed to both, depending on the area. Okay, so it's kind of some good things to try out, you know, among your classmates here. pretty much in the realistic world, you're probably gonna have a third person there anyway. Just to kind of, you know, liability issues, so to speak. Okay. So what I'd like to do is have you break up into, and I think you're 9, so it'll be a group of 3 and then a couple groups of 2.